A patient follows every guideline. They take their prescribed statins, they manage their diet, and their low-density lipoprotein cholesterol, LDL-C, drops well below the recommended treatment threshold. Yet a coronary artery abruptly occludes, resulting in a myocardial infarction. This scenario occurs frequently in preventive cardiology because relying strictly on total cholesterol mass leaves a diagnostic blind spot. Measuring the weight of cholesterol inside the lipoproteins fails to tell us the actual number of particles circulating in the blood or how biologically aggressive those specific particles are. The clinical picture of atherogenesis is determined by a precise triad of biomarkers: Apolipoprotein B 100, Lipoprotein A, and high-sensitivity C-reactive protein. Each marker measures a distinct compounding mechanism of vascular disease. Apolipoprotein B 100, or ApoB, counts the absolute burden of atherogenic particles. Lipoprotein A, or LPA, quantifies a specific, highly thrombotic inherited risk. High-sensitivity C-reactive protein, or HSCRP, tracks active systemic and vascular inflammation. When these three variables compound, they generate a highly volatile vascular environment. To accurately map and neutralize a patient's true cardiovascular risk, clinical practice must evolve past the pure cholesterol mass hypothesis and target this integrated, particle and inflammation-driven model. Standard lipid panels typically rely on the Friedewald equation to report LDL-C. The Friedewald equation is a mathematical formula historically used to estimate LDL cholesterol based on total cholesterol, HDL, and triglycerides. This calculated mass metric loses accuracy when triglycerides are elevated, and it completely fails to measure the actual number of atherogenic vehicles in the blood. This creates a phenomenon known as LDL-C/ApoB discordance. Patients with metabolic syndrome or type 2 diabetes often shift toward producing small, dense LDL, or SDLDL. SDLDL refers to cholesterol particles that are physically smaller and heavier, making them more likely to penetrate artery walls. A patient can have a low total cholesterol mass, but carry a massive, highly dangerous number of these small particles. We can count these particles directly due to a strict physiological rule. Every single potentially atherogenic particle, whether it is VLDL, IDL, standard LDL, or LPA, carries exactly one ApoB 100 molecule on its surface. Because of this exact 1-to-1 ratio, clinicians can use immunoturbidimetric methods to get an absolute particle count. Immunoturbidimetric methods are laboratory techniques that measure the concentration of a substance by analyzing how much light is scattered by antigen-antibody complexes in a fluid. Measuring ApoB bypasses the mathematical errors of the Friedewald equation. Atherosclerosis does not begin because the blood contains too much abstract cholesterol mass. It begins because physical particles enter the arterial wall. A direct ApoB particle count is inherently superior for assessing the likelihood of that intimal infiltration. To understand why particle count dictates risk, we have to look at the arterial endothelium. This smooth barrier is regularly subjected to shear stress, oxidative injury, and chemical exposure. When compromised by these factors, the endothelium becomes permeable. ApoB-containing particles easily drift through these permeable gaps into the subendothelial space. But entry alone does not cause atherosclerosis. Plaque formation requires permanent subendothelial retention. Inside the intima, positively charged ApoB 100 molecules electrostatically bind to negatively charged sulfate groups on arterial proteoglycans. This magnetic lock traps the particles inside the vessel wall. Trapped, these lipoproteins undergo enzymatic and oxidative modification, degrading into highly inflammatory immunogenic structures. These modified lipoproteins act as damage-associated molecular patterns, or DAMPs. DAMPs are molecules released by stressed or dying cells that trigger an immune system response. They recruit monocytes and drive the formation of lipid-laden foam cells, the earliest histologic hallmark of an atherosclerotic lesion. Tracking this precise sequence of physical retention required decades of international standardization in laboratory immunoassays to reliably quantify ApoB concentrations in clinical settings. The math is unforgiving. The higher a patient's ApoB count, the greater the statistical probability of electrostatic trapping in the arterial wall. ApoB is the prerequisite raw material for plaque initiation. While ApoB provides the raw substrate for plaque, certain particles carry severe independent risks. Lipoprotein A is a highly pathogenic particle governed almost entirely by the LPA gene on chromosome 6. Its concentration is up to 90% heritable and remains largely immune to diet, exercise, or lifestyle modifications. LPA has a unique architecture, an LDL-like core linked to apolipoprotein A by a disulfide bond. Its danger comes from Kringle 4 type 2 repeat domains. Fewer KIV2 repeats create smaller ApoA isoforms, which the liver secretes more efficiently, driving dangerously high LPA concentrations. This creates a permanent, lifelong genetic trap. Elevated LPA silently compounds the baseline risk established by the ApoB particle count, operating entirely outside the patient's behavioral control. LPA amplifies cardiovascular risk through two simultaneous synergistic pathways, accelerating plaque buildup while destabilizing the arterial environment. The first is an atherogenic and inflammatory drive. LPA acts as the primary plasma carrier for oxidized phospholipids, or OXPL. OXPL are highly reactive, modified fat molecules that strongly provoke tissue inflammation. By carrying OXPL, LPA delivers concentrated inflammatory ligands directly into the subendothelial space. The second threat is thrombotic. The ApoA protein shares a striking structural homology with plasminogen, the body's natural clot-dissolving enzyme. Looking structurally identical, LPA competes with real plasminogen for binding sites on a fibrin clot, physically blocking the active enzyme from dissolving it. This competitive inhibition actively impairs fibrinolysis. When a plaque ruptures and a clot forms, LPA ensures that the body's natural mechanisms cannot dissolve it. LPA accelerates the necrotic breakdown of the arterial wall with its oxidized lipid payload, guaranteeing that the resulting rupture causes a catastrophic, persistent occlusion. As oxidized ApoB and LPPA particles accumulate, the local immune system reacts violently to the trapped lipid burden inside the intima. Macrophages ingesting oxidized lipoproteins are overwhelmed, triggering the NLRP3 inflammasome. This complex releases cytokines, mapping a precise cascade. IL-1 beta triggers IL-6 signaling, which travels to the liver. The liver then synthesizes C-reactive protein, or CRP, providing a measurable metric of arterial inflammation. The clinical importance of this was confirmed by the Jupiter trial. This major clinical study proved that lowering inflammation reduces heart attacks, even in patients with normal cholesterol levels. It demonstrated that chronic, low-grade hsCRP elevation above 2 mg per liter drives severe cardiovascular events, regardless of how well a patient's LDL-C is managed. Elevated hsCRP functions as a localized smoke detector for active vascular necrosis, signaling that the plaque is inflamed, physically degrading, and moving rapidly toward rupture. ApoB, LPA, and hsCRP do not operate in isolated vacuums. They act together, forming a self-reinforcing pathogenic loop. ApoB provides the physical substrate for the plaque. The resulting inflammation, measured by hsCRP, degrades endothelial function, allowing even more ApoB to enter the tissue. Meanwhile, LPA accelerates the localized damage and ensures that when the weakened plaque finally fractures, the resulting clot will not dissolve. This 3D risk map illustrates the findings from over 320,000 UK Biobank participants, quantifying the isolated risk of major adverse cardiovascular events, or MACE. MACE is a composite metric that includes severe clinical outcomes like heart attacks, strokes, and cardiovascular death. In isolation, high LDL-C elevates MACE risk by 13%. High LPA elevates it by 8%. High hsCRP elevates it by 6%. When a patient exhibits a triple elevation of all three markers, individual risks compound into a massive 77% spike in major cardiovascular events. To understand the severity of this biochemical profile, we must compare it to aggressive behavioral toxins like cigarette smoking, which causes massive oxidative stress and direct endothelial injury. The INTER-HEART study mapped this specific dynamic. INTER-HEART was a massive global study across 52 countries that identified the most common, modifiable risk factors for heart attacks. While current smoking carries a severe individual odds ratio for myocardial infarction, The population attributable risk for global dyslipidemia, measured by the ApoB to ApoA1 ratio, is 54.1%, compared to just 35.7% for smoking. Ignoring any single pillar of this triad, particle count, genetics, or inflammation, leaves the patient exposed to exponential, unmanaged risk that rivals and often exceeds the damage caused by severe lifestyle factors. Statins remain the foundational tool for lowering LDL-C and reducing total cholesterol mass. However, they do not lower LPA. In fact, multiple studies indicate that statin therapy may modestly increase LPA levels by 10 to 20%, leaving a massive portion of the risk triad completely unmanaged. The clinical horizon now includes PCSK9 inhibitors, as well as ASOs and siRNA platforms targeting the LPA gene. PCSK9 inhibitors are a class of injectable drugs that help the liver clear more LDL cholesterol from the blood. ASOs, or antisense oligonucleotides, are synthetic strands of genetic code designed to block the production of disease-causing proteins, while siRNA is a targeted therapy that silences specific genes before they can produce their corresponding proteins. These emerging therapies have shown the ability to reduce LPA by up to 90%. Targeting inflammation directly is also becoming viable, as demonstrated by the CANTOS trial. The CANTOS trial demonstrated that directly reducing inflammation lowers cardiovascular risk independently of cholesterol levels. By neutralizing the inflammatory signaling pathway, clinicians can reduce MACE by stabilizing the plaque and preventing rupture. To reverse atherosclerotic progression, the medical focus must shift. It is no longer enough to lower total cholesterol mass. True preventive cardiology requires quantifying the exact particle burden with ApoB, identifying the genetic thrombotic threat of LPA, and neutralizing the active inflammatory cascade measured by hsCRP.